Well, it's a pleasure to be here. I planned this for a long time, so it's really great that it's come to fruition. And I've already had a chance to be around Dublin a bit and visit Temple Street Hospital and hear a little bit about the situation with children's hospitals in Ireland. I was able to speak to some of the classes as well. So just as for my sake, can you raise your hand if you are a healthcare professional? Oh, lots of people. Great. What about if you are, I'm not going to single you out as a parent, what if you know someone with autism? So it's still a lot of people. And you could, some people are healthcare professionals and know someone with autism too. So there's that group. Anyone here from a local autism society? At all? No one from the Autism Society? No. Okay, thanks. What I wanted to do today was to do a basic class in what is autism as of 2018. And PhD people like to define every term we use. So really, how do we define it? How is it screened for and diagnosed currently in the United States? And then talk about behaviors of children and adults with autism, what we see on the outside, and what are they at home and what are they in the healthcare setting, and how is that challenging for healthcare professionals and parents. So I'm from Milwaukee, and that's in the Midwest, USA, where the red dot there is. It's a city similar in size, I think, to Dublin, about the same size. It's on the water, and we have a beautiful Calatrava Art Museum. Like heck, you have a bridge, beautiful Calatrava. We have this giant medical center. It's 300-bed, 72-bed ICU, a separate clinics building, a separate office building, lots of skywalks, Ronald McDonald House, a family resource center on the main level, valet parking, and then it's connected by all these underground tunnels to the adult hospital system called Freighter, to the curative rehab system, and then to the county mental health complex. Then it's also connected to the Medical College of Wisconsin, and the physicians come from the Medical College. The hospital itself has a lot of nurse practitioners, and probably about 300 that work in all the specialty clinics, and even as hospitalists, and we have 6 or 8 that work in the ICU, and we have 12 PhD prepared nurse scientists in all the different areas. The consortium is across 2 universities in the Children's Hospital, and we are working on an app right now to facilitate family engagement at the time of discharge. And so there's sort of a lot going on in terms of research at Children's, and a lot of advanced practice nursing roles. It's really sort of blossomed in the last 10 years. So by the end of this class, I would think you'd be able to tell, if someone asked you what autism spectrum disorder was, I would think you'd be able to give them a sentence about what it is and have a good idea of how prevalent it is and maybe what causes it and what you see. And then a couple ways to screen and diagnose it, and then go away with some skills for managing behavior and giving people some ideas of how to do that. The whole talk's going to wrap around a little case study here that goes throughout the talk. Since we're mostly healthcare professionals or know someone with autism, if a mother were to bring her 18-month-old son John into your clinic or hospital or emergency room or wherever you are, school, we have well child checks, and you get your immunizations at those, and you get some anticipatory guidance. And she's saying, you know, he's not pointing like his sister to things and looking at me, and every time I call him, he doesn't answer. And his tantrums are horrific, especially when he's transitioning. When I ask him to get up from the table or go to bed or stop playing with a toy and come along because it's bath time. Those are all the times he just has a complete meltdown. So you want to be really aware of those things, the not turning to your head when your name's called, and the not pointing and sharing enjoyment. So keep those 2 as real keys here. So what is autism spectrum disorder? It's lifelong, it's brain-based, and we know it's there at birth, and we're almost positive it's there at birth, but we can't always see it because it's very subjective in terms of how it's presenting. There's 2 domains now, according to the American Psychiatric Association's manual called the Diagnostic Statistical Manual of Mental Disorders. and that's put out by the American Psychiatric Professional Society. There's been 5 iterations of that, and in the most recent one, they've narrowed it down to just 2 domains. And language and socialization are together now in one domain, and then the other one is restricted repetitive behaviors, or unusual interests. So that's very broad, and that's going to be really hard for a parent to sort of know what that is. If you asked a parent about a child's speech, they'd say, well, he's saying single words or putting 2 words together, or he's sitting, standing, walking, jumping, running. Those are very objective, observable items. But things more of the social nature are much hard to put into words for parents. And there's usually varying opinions on whether someone's meeting their milestones. If you are working in pediatrics, there's scales, Denver developmental scales, that let you know what you should be doing at those ages in terms of socialization and language. But your typical parent isn't versed in what all those steps are. So what we're finding, though, is that there's lots of different levels of severity. So if you wanted this disorder to be an easy one, it's not. It's a big, long scale from mildness to severeness in language, socialization, and repetitive behavior. Repetitive behavior is flicking the light switch off and on, running the water and putting your hand under it, jumping up and down, flapping your hands, spinning, pacing, those types of things. So under social communication interaction, it can be either expressive, and I'm expressing right now, but if you were to start asking me questions, that would be me with my receptive language. Either or both can be delayed in kids with autism spectrum disorder. Then they have a real issue with the pointing, sharing enjoyment. I always look at toddlers, because I've been a nurse practitioner a long time now, and if they're walking or toddling around with their little finger out, I'm pretty sure things are good. And they call their name and they turn, things are good. But a child who doesn't really point, who's lining toys up, playing incessantly, hard to get their attention, and waving backwards to themselves or not at all, those are kind of red flags. They might develop ways to communicate, but they may be atypical. They might take mom by the hand and drag her to the fridge and grunt in order to get something out of the fridge. Very much cause and effect, do something in order to get something. The other thing that sometimes happens is there's this history of regression. Skills can be met, but then all of a sudden a parent might notice, wait a minute, they're not doing what they used to do anymore. And if that happens along with having had a fever or having had a shot, that's when we run into trouble about cause and effect. It could be something correlational going on, but parents get concerned. Typical social interaction could be you're sitting on the couch, a couple people watching TV, and the toddler comes along, stands in front of you and jumps up and down and flaps their hands. They're looking at you and they're laughing, but that's not a typical way to engage. They could overstimulate very easily, so instead of being able to make eye contact with you, they might get enough just by looking at you through the corner of their eye, and that's enough. So they still see you, but it might be just too hard for them to. And all of these things can be taught eventually with some therapies, and that's why it's good to sort of get early notification of these things and some training in order to be able to increase language and increase social skills. So the restricted repetitive behaviors, hand flapping, finger flicking, some issues with sounds, loud sounds. See kids wearing headphones so that when they're in places at basketball games or whatever, in order to, because the sounds are too loud. Tags on clothing, certain textures might be itchy. And then, so there is prolongation of having tantrums. When you think of a 2-year-old who has a tantrum because they don't get what they want. Kids with autism spectrum disorder sometimes persist with that their whole life. Even as adults, if things don't go their way, they could get quite angry about it. Right? And some of them are quite hyperactive, or they could be hypoactive. And the big issue with healthcare professionals is this is not what we like in our patients. We like our patients to come in, tough it out, stick out their hand, do what they're supposed to do, and keep our appointment schedule going along. So it requires us in healthcare to come up with some different processes and strategies. What we have in the United States is the Centers for Disease Control in Atlanta, and they are the ones that are in charge of public health and immunization schedules and what we should be getting. They're also in charge of child development now and a Learn the Signs Act Early campaign so that people will see the signs of autism long before they get a bunch of immunizations that they then think might be the cause of the child's autism. So not that the two are, one was developed for the other, but it's nice to have all the information at the same site. Okay, so according to the Centers for Disease Control, the two key things, if you're going to learn anything about autism, other than the fact that it's language and socialization, and then the second one is repetitive behaviors, is this pointing and the name. So I want to show you, they have a phenomenal site with all the different videos for all the different names. So this is Evan. He is 18 months old. So watch Evan here.
You want to try to see if you can get him to respond to it?
No. Mm-hmm. Evan. Evan. Evan.
See maybe if you can get him to respond to you now, you can use touch with his name, like give him a little tickle or something.
Evan. Evan. Evan.
He likes the tickles, but he's just not giving you too much eye contact, but he does smile when you tickle him.
Evan. Evan. Evan.
So we have some absolute indications for referral for autism assessment. So when I say referral for autism assessment, that's a bit of a mouthful, right? So some things are going on with your child, and you might take them to the pediatrician or a nurse practitioner if you're in the States, because a lot of them do primary care. But there's so many things to track, right? There's physical, there's language, there's social, there's fine motor, whether they're tying their shoes or doing their buttons. So there's all these different domains, right? So the Centers for Disease Control has come up with this list. And it's no babbling by 12 months. Does anyone know when you should be saying ba 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 bye? Anyone have babies? Yeah, right. Even by 6 months, right? No gesturing, pointing, waving by 12 months and turning head to name. You should be doing that by about 9 months. No single words by 16 months. When do kids have single words? Usually by a year. I have the rule of single words by 1 year, 2 words together by 2 years, 3 words together by 3 years, right? Up, and then want cookie, and then by 3 years, I want cookie. Or 2 word spontaneous phrases by 24 months, not echolalic. Do you guys know the word echolalic? Yeah. So it's repeating back exactly what I say instead of giving me the answer. That fools parents too, because they think they're talking, but they're just repeating the question. Or any loss of language or social skills at any age. So that's what it is. So now you know what it is. It's social and language, and it's repetitive behaviors. So you should be able to say that now. And then not turning to your name and not pointing by around a year. Prevalence. Because it's had so many different names and definitions, the prevalence changed since 1980. Before 1980, there wasn't even autism. There was early onset schizophrenia in this book, the DSM-1. So we've had 5 iterations of that, and every time it comes out, there's a new definition for autism. So I showed you what today's definition for autism is. According to the DSM-4, the prevalence in the States is 1 in 68 people. We don't have a prevalence study yet for the new DSM-5. And about 4 times more boys have it than girls. This study, done by the Autism Developmental Disabilities Monitoring Network, is the prevalence study I'm referring to. It's one of many prevalence studies. This prevalence study was done in 14 communities across America by looking at school records of 8-year-olds and seeing if they had a diagnosis. But if you can believe it, kids older than 8 sometimes get a diagnosis later in life, so we can't even be sure that the prevalence isn't higher, because we could have missed kids. This is just a graphic showing over the years how the prevalence has gone up. And that down this side on the right, there's different people who did these studies, and it was according to different books. So the DSM-3, the DSM-3 revised, the DSM-4 is the red one, so that's the most recent study, the red dots. So how's it diagnosed? We don't have a definitive biomarker diagnosis to say you have autism. For Down syndrome, if you have trisomy 21, For Fragile X, if you have, those are single gene disorders. So those are actually kind of, in these day and age, if you've heard of Rett syndrome, girls who have Rett syndrome, in the old DSM-4, Rett syndrome used to be a category of autism until they found out it was a single gene disorder. So that's where we're heading. Right now is the state of the science on autism now. It doesn't mean it's going to be the state of the science tomorrow. It's what we have now. The gold standard test right now for children who have these not pointing, not passing this MCHAT screening or getting a diagnosis of autism is to get a genetics evaluation and have a microarray analysis done. That screens all 23 pairs of your chromosomes. By looking at all your chromosomes together, chromosomes have genes on them. By looking at all of them together, that's called the genome, the whole thing. Genetics is about individual genes, okay, so the whole genome. So it's a whole sequencing. And so that's the gold standard. And what we're finding is that it's not a single gene disorder. We're finding that you can have genetic disorders on 6 or 8 genes for this child. You could have them on completely different genes on this child. 2 different children with the same genetic anomalies, one could have autism, one could not. So we don't have an answer. So there's still lots of research going on about that. But there is still some thought that it's genetic predisposition with possibly some form of either immune or environmental link. Then there's this other suspicion that you're born with genetic susceptibility and then it has to be triggered somehow. Similar to cancer. And that we're skeptical now about what are some of the environmental factors. So if you look at me, I'm a phenotype. I have freckles, I have detached earlobes, I have green eyes. That's my phenotype. If you were to look at my gene profile for my eye color or my ear color, that would be under the microscope. So phenotype is a set of observable characteristics resulting from what I have in my genes to possibly the environment itself. And we think that with autism, the phenotype for autism is really vast. You can have someone who has really poor socialization but a full vocabulary and no repetitive behaviors, or just when they're very anxious, the repetitive pacing could come out, or some kind of self-injury, hitting or head banging. But, or you could have someone with no language at all, not able to do their own personal care, really severe self-injury. So what we're saying is we think that that somewhat might be linked to different genetics in combination with environment. But again, there's still work being done on that. So when we talk about these core domains of language, socialization, repetitive behaviors, and even to some extent obsessions, anxiety, all the different disorders, we're saying that those are items or symptoms that are also in our general population, right? But maybe to a milder extent. So someone who's very rigid and very routine-oriented could be a very successful person if they had good language, had good social skills, whether through training or just through who they are. So we know that all of these traits in autism do exist in other people in society, which again leads us to think that it's possibly genetics. So what we're seeing with autism research is what they'd love to do is take this phenotype, what I see here, this boy, he's got some speech and he has these challenging behaviors and seizures, and match that to a genetics. So that eventually we'd be able to separate all this out. This genetic profile, like Rett syndrome, with autism is this. That's the goal of research. We're hoping lots of different genotypes that match lots of these different phenotypes. Other evidence for why we think it's inherited is identical twins share 60 to 90% of the traits, compared to if you have non-identical twins, they don't. I know of twins, identical twins, the one boy's quite severe autism, the other one's appears neurotypical. Maybe he has some anxiety or something, but he's in a typical classroom. So I personally have seen identical twins where one has severe autism and the other doesn't. So that speaks to the fact that it's not just genetics. It must be something environmental or something that got turned on. Some gene was susceptible. We see it more in families, and we see it occurring with single gene disorders. 40% of kids with Downs also have autistic tendencies. So we're seeing these shifts in diagnostic criteria over time, as I mentioned, across those 4 iterations of the manual, and it definitely has had an impact on the prevalence. There could be a true increase. There's people in California that are really getting different professional organizations together thinking it's environmental causes. So, stay tuned. It could be something in the environment. But what we do know is there's not one single risk factor. It's not like this one thing causes it. It could be multiple things. Some thought that viral infections while you're pregnant could be the problem. Stress hormones while you're pregnant could affect the maternal environment. There's been studies done looking at, there's an increase now in IVF and artificial insemination, ovulation-inducing drugs in the States, Pergonal. Older mothers, influences other than the environment, such as pollutants, people who live closer to farms, people who live closer to highways, pesticides. So all these things are being looked at. So in the center here we have phenotype, which is again what you look like. There could be issues with gene expression. So you might have the gene, but whether it expresses itself or not. There's issues with epigenetics, which are changes in genetics after you're born. And then there's other issues with, there's something called histone methylation you might hear people talking about, where methyl groups are transferred to amino acids, which are the building blocks of proteins, and change your chromosome structure. So there's lots of studies going on in the States like this. I give you an example here that you could look at, that there's actually your genes are being changed after you're born that affect your behaviors. So this is just a quick reminder on genetics. This is a single gene, and we have 23 pairs of chromosomes. And you'll see that makes up your DNA. We can have brand new mutations too, is another thing. Like, it doesn't mean that you inherited it from one side of your family. It could be a brand new mutation when you're born. And we have a big interagency autism coordination committee in the States that does a lot of pulling together all the different research centers across America so that we're not duplicating with government funds. So this is the interesting stuff that I see as practical for your healthcare professional. If you look at certain genes, you can see that this ingrailed2 gene is responsible for cerebellum development. This GABR gene is brain migration, and you'll often hear about people say that autism is related to at the in utero stage, differentiation of cells is the problem, formation of synapses. You'll see issues with the gene that's responsible for oxytocin receptor, which is your stress response and social skills. The reelin gene, which again, neuronal migration, and some kids with autism have large heads, so they think that that's an issue. With that, serotonin transporter, think of medications that kids with autism are on, a lot of serotonin, select serotonin reuptake inhibitors like Prozac, things for anxiety. So it makes sense that the genes responsible for those things might be a problem. So we have some genes that have been identified, chromosomes on these genes in kids with autism, for genes that are responsible for body planning, and sometimes kids have trouble with coordination. They have trouble tying their shoes, doing the hand over hand in the gym bars. The amygdala is really responsible for social behaviors, being able to take turns with a conversation, not putting non-food things in your mouth, eating too quickly, all the kinds of things that you can usually learn as a social behavior. Speech language disorders, anxiety, even epilepsy. So some of these things, this is the work that's being done. And I think if you put it to behaviors of things that we see, it sort of makes more sense that they're spending time on this. Language, obsessions, intellectual disabilities. So this is sort of the last slide on genetics. I'm by no means a geneticist. I did a bachelor's of science, and I wrote a paper on autism and genomics for the Journal of Nursing Scholarship, and I did the Summer Institute at the NIH for genetics, but by no means. So that's what's great about autism research, is doing interprofessional and working with geneticists to understand it better. So about 5 to 10% of autism spectrum disorders have associated syndromes. And what this means is if someone has Klinefelter's or any kind of X or Y linked disorder, or if they have tuberous sclerosis, you want to make sure that they're screened for autism. That's what it really means for you. So how do we screen? In the United States, we have the American Academy of Pediatrics. It's a professional organization of pediatricians. They come up with policy, just like the American Psychiatric Society came out with their book. So two completely different organizations, even though they're both doctors. Neurology Society also has its own ideas about autism, as does nursing and nurse practitioners. So the American Academy of Pediatrics came up with a policy, though, that they want their pediatricians that are members and practicing to do surveillance. And we do it, and nurse practitioners do this as well. And about 60 to 70% of people are actually doing it. It's not reimbursable, and most things are really only done if they're reimbursable in the States. So that's a push to get that to be something that gets a reimbursement. But we do it standard at these ages, and the screen that we use is the MChat. And I brought a copy of it, and I'm just going to pass it around. It's available online, so I just brought one copy. These are the questions. I'll just give it to you first. You can pass it around and just look at it. And the parent is the one who gives you the answers. It can be done online without even coming in for an appointment, and it can be scored, and it can tell you if you're at risk for autism, and then you would go to further actual diagnostic testing. We really encourage early diagnosis in order to get into some of the programming we have in the States. We have early childhood education and a birth to 3 type programming, because we think the brain's plastic, and we can help children more if we catch it early. But that means you have to know what the developmental milestones are, and understand what the developmental screening is. So you're looking at the handout as I pass it around. There's some questions on there about the pointing, the waving, does he like being tickled, all those types of things that you're going to see. So if they fail that, they're going to get some further testing, which is quite in depth. And it's called the ADOS, and it's a diagnostic inventory of doing puzzles and all kinds of things. You get put in a position a lot about, well, how do we tell parents this? How do we tell them even to go get screening? I've had many people say, well, I have a friend and their child looks delayed, but I don't know how to talk to her. So that's why I just thought I'd show this, because I think this is a short video about communicating to parents why they should go in to get their child screened and tested for autism.
The following video role play was staged with an actual physician and with real parents of a child with autism. In this role play, Tommy, the patient, is 27 months old. His pediatrician saw him at his 2-year well check, expressed concerns, and asked the parents to fill out a questionnaire. They're back in her office today.
It's good to see you both. I'd like to take a few minutes and look at the questionnaire again that you completed.
Yes, we filled that out after the last visit, and he's made a lot of progress. He knows more words now.
That's great to hear. A growing vocabulary is a really good thing to see. I'd like to take a look at some of your responses to the questionnaire and just see if anything's changed since you filled that out.
Like what?
You had answered that he's not really interested in other kids.
Yeah, that's just his personality. He kind of likes to be alone and do his own thing.
Mm-hmm. Tell me more what you mean by that.
He gets very upset with any change in his routine. He likes playing with his toys for a long time, and he's very creative. When he's playing on his own, he just doesn't like any other kids to interfere. But isn't that normal for a toddler?
You're right. Young children often do not like it when their routines are disturbed, and will get upset when that happens. And you know, when kids are really busy playing, they don't like to be disturbed. But some of the things you've told me about Tommy's social interactions raises some concerns, and I'd like to understand that a little bit better.
He knows what he wants. He's very independent and likes playing by himself. He's kind of shy. Most of my family is shy. Tommy takes after my side of the family.
Oh, it's interesting. You've sort of noticed some similarities between Tommy and other people in your family. So let's look. You know, I'd like to hear a little bit more about your reporting that Tommy doesn't point or follow your point.
Right. I don't know why he doesn't point. Whenever he wants something, he just carries me to what he wants. He gets really frustrated if we don't understand what he's asking for.
That must be frustrating for the two of you to not always know what Tommy needs. Let's take a look. So you had also indicated that he doesn't respond to his name. Can you tell me a little bit more about that?
No, he won't respond when you call his name, and he won't even address me as mama.
My wife and I, we kind of disagree about this. He responds well when you get close and you touch him. He just doesn't respond well from across the room.
I see. Is he in daycare or preschool?
No, we tried preschool. It was an absolute disaster. So now we just keep him at home. He seems a lot happier being at home by himself.
Tell me what you mean by a disaster.
Well, the school, he was more rigid. He wasn't interested in playing with the other kids. He just kind of liked playing with the shapes and blocks and that sort of thing. But I just don't think preschool was a good fit for him.
Boy, it sounds like that was really unpleasant for Tommy and for your family as well. How long was Tommy in preschool?
Only about 3 months. The teachers felt that he wasn't ready for preschool.
I see. Well, I'm glad we've had some opportunity to review your responses to that questionnaire in a little more detail. And I really recommend the evaluation with the developmental and behavioral pediatrician. And based on what you've told me, I still have some concerns about Tommy's social and communication skills like we had talked about last time. So I am so happy to hear that Tommy is making lots of nice gains, has a growing vocabulary, but I do still have some areas of concern.
Well, we were uncomfortable with something being wrong with him, and we really weren't sure what you meant about evaluation. But he's made a lot of progress. Do you still recommend this?
Yes. The questionnaire that you completed does not provide us with a diagnosis, but it does suggest that there are some things about Tommy that we need to look at a bit more closely. I am still concerned that some of the behaviors you've described suggest that Tommy's a bit less social and less communicative than I would expect.
What will they do? Put him on medication?
We're not talking about medication now. We just need to get some more information and to understand Tommy a little bit better. So there may be one clinician or there may be a team of clinicians, I'm not sure. But they're going to really use that time to observe Tommy, to really look very carefully at his social and his communication skills. And they do this by using child-friendly toys and materials, so puzzles and maybe blocks and different kinds of things like that. You know, the evaluations are designed to try to make kids feel comfortable. They're not meant to be scary. They can be tiring because they can be long, but they're not meant to be frightening to children.
Okay, well, all right. Sounds like you really want us to go through with this.
I think it's a good idea, and I'd like to hear from you. I'd like to stay in touch and hear how the evaluation goes and get your impressions about, you know, how you think it went.
Okay, doctor, we'll do it.
Probably about 50 videos on this website. And again, it's meant to give you more information so that you get some, I guess, build a little self-efficacy about talking to parents. Because there's always that fear of offending people when you see things, and it's not cut and dry. We are, again, a real advocate of getting into what we call a birth to 3 system. It's through our schools. You go into your local school and they'll get you into birth to 3, which is an early program. And we have a law called the Individual with Disabilities in Education Act that enables early intervention, special ed, until kids are 21 years of age. And our therapies, speech, and OT are in the school, and the schools are the one who drive the whole programming for autism in the United States. The testing that this family is going to go to is called multidisciplinary gold standard. It's the ADOS testing, and can be by a developmental MD. It can be by an advanced practice nurse if they're trained in it. And that is completely separate from cognitive evaluation or IQ. So when you hear of someone has an intellectual disability, that's referring to their IQ. Generally, it's an IQ under 70. So not everyone with autism has intellectual disability, and not everyone with intellectual disability has autism, so they're separate. Some kids never get any kind of evaluation at all, but an educational determination is made in the States, and they still will get school. So let's go back to John. We heard about him at the beginning. He now has, remember wasn't pointing and he's having tantrums. So now he's been diagnosed with autism, and the parents got the results of the diagnostic evaluation. So now they have to figure out what interventions and treatments are recommended. Anyone know what might be recommended? Put it out there. Now that he has autism, based on what his delays are? I hear speech. What else? OT. Those are two, right? Anything else? Okay, so maybe cognitive behavioral if he's got the ability, a good cognition, that doesn't have an intellectual disability, has good language. Play therapy. Okay, anything else? Okay. All right, so in the States, the recommended intervention would be going into that early intervention. If they're already over 3, they go into a different one than if they're under 3. Speech and language therapy, so that's it. Occupational therapy. If they have any gross motor issues, they might get physical therapy. Some kids with language disorder will have toe walking and they'll have tight heel cords. So maybe they need something for that. They could have a board certified behavior analyst. It's a big program now in the States, a BCBA. And there's been some books written in the States that everyone's read about getting ABA therapy. And depending on the state, it could even be paid for by state insurance. If you get the diagnosis of autism in most states, there's a law now that parents have lobbied for where your private insurance has to pay for ABA therapy in about 45 of the states. So if your private insurance pays for it, that means the government doesn't have to pay for it. So the government loves that law. That means all these private insurances have to pay for it. But if you don't have private insurance, then the states will pay for it. But it's only, to a certain age. And that changes routinely all the time. So I think now it's only up until about 8 years of age that you get it until, because they think that brain development is at its peak by then, but again, depending on the study you read. And then medical treatment and follow-up, because you can see that there's going to be a lot of issues along with the autism. It's not just the language and the behaviors. There could be some medical problems too. Many different forms of ABA. The first ones were Lovaas, and he used aversives, meaning punishment if they didn't do what he asked. So now the programs these days are much more positive for rewards, but most of them have this thing called discrete trial, where there's a stimulus such as do this, or put the block in the bucket, or sit in the chair. That's the stimulus. And the response is the child either does it or doesn't do it. And then your response then after that is good job, or tickle, or a piece of food. So it's like it's a training way. So a lot of kids are trained to sit still. They're trained to read by getting a reward for every time they say the correct thing that's on a card, and then you build a word wall. At, am, and they say it 5 times, and people take notes. They get their rewards. And they get 40 hours of this a week in the home. So a lot of people don't put their kids in school, and they do this. Somebody different comes every 2 hours, pulls up to your house, and that goes for a few years. Sometimes can go, several years. And they can help with toilet training, all kinds of things. So it's thought to be really helpful, and people want that therapy. Other kinds of programs, rapid prompting method. It's a stencil board with letters, and the nonverbal kids will get a pencil and they'll answer by tapping letters. There's parent training programs out there. I think there was a presentation here yesterday, the triple P method of positive parenting. CBT someone mentioned. And lots of video modeling and social scripting. In some sense, I just video modeled how to have a discussion with a parent. So we do that with kids with autism. We show them videos of how they should behave. So what else goes along with autism? Kids with autism are more prone to seizures, and often they'll have their first seizure when they're teenagers. And there's gut issues. The NIH thinks the microbiome of your gut drives your behavior, and a lot of literature has come out of the States. Since I've been here, I've talked to some different people here who think the diet, the narrowness of the diet, affects the gut. So again, it's still in early science, we don't know. But the point is kids could have gut problems. The biggest one though, that is constipation or diarrhea. So if you're looking after someone with autism, you really have to, I'm a nursing instructor, you really have to keep track of the bowel movement. They can get a megacolon and have just encoparesis, which is stooling around it, and that could be a big driver of their behavior. So you always want to make sure that you know what's going on with that. They can have regurgitation, and if you don't have speech and you can't tell anyone, they could do self-injury. And then sleep seems to be a big problem. So we're going to get into medications and things about that. Troubles with feeding, narrowness of food. There was a case study of a little boy who had scurvy because all he ate was Cheerios, didn't get any vitamin C. And who'd think that someone in the middle of America would have scurvy? The other thing is we're not positive they feel pain in the same way. So we think it's altered pain perception. We had a boy that was cold at the hospital and he was hitting his legs. As soon as they put a blanket on him, he wasn't hitting his legs anymore. That doesn't mean every time someone hits their legs they're cold, but you could rule out a few things like temperature, pain. You can, say touch what hurts, or draw a man and give him a pencil and say put an X on what hurts. Again, that's getting at the fact that a child might not have expressive language, but they might have perfect receptive language. So I always want to go with the fact that they have receptive language. All right, John's back again. And he's got some problems now. So he's got his diagnosis, he's getting his treatments. So you're going to go over with the parents some of the things that you know about managing some of the problems and strategies, and maybe even start talking about medications. Because that always comes up. There's always family members or neighbors or teachers who want to get these behaviors under control with medication. So what are the behaviors of autism? Anxiety. So it's usually, if you're anxious, say you're at an airport and the plane's delayed, it can make you a little anxious because you don't know what's going to happen next or what time it's going to come. What would be the thing that would help your anxiety the most if you're in that situation? You don't know when it's going to take off. Information, right. So if you hear the announcement and they say, your flight is now leaving at 12:30, and you look at your watch and it's 8, your first instinct is, oh, but then you think, okay, I'll go get dinner. And then you've reset your expectations to 12:30. But if you're a nurse or a physician looking after someone and you think, oh, they don't talk, it doesn't matter. You still want to give them information. So information is always your go-to with anxiety. Kids could have routines and they want it done in a certain way. So when in hospital or in healthcare settings, make the list, get the information from the parent who knows the child the best, and go with the list in that order and cross things off as you go, just like you do with your own calendars. The other thing is aggression, agitation, self-injury, which is so sad to see. Got some more information on that coming up, but really it's thought to be a form of communication, and so we always want to see the antecedent to it so we can maybe prevent it in the future. But I've got more on that. And then obviously social skill deficits, inability to sit when you ask them to, follow the instructions. They point out, and it's sometimes impolite, point things out that normally people would just keep to themselves. So sometimes kids end up going on medication, and oral can be hard, right? So because they could have sensory problems or they haven't learned how to swallow things, and they're not often ones to just say, hey, I'm just going to figure it out today. But they can learn all this stuff. They definitely learn to swallow pills, and so it's just coming up with a plan to work with them to get them to do it. Then try to figure out with the challenging behaviors what's provoking it, like anything. Sometimes some of the behaviors of kids with autism are more concerning to the people around them than the kids themselves. If they're pacing or chewing a straw, they're really not hurting anybody. So, or having, a few tics. Sometimes we have to stop and think, is it just upsetting to us because we can't control them, or is it really something that's dangerous? We do want to be concerned about just over-prescribing medication and chemically restraining kids. So it's a careful selection process. Try to figure out what are all the medical things that could be going on. Is he constipated? Now he has a UTI. Does he have a headache? You know, what else could possibly be going on? Appendicitis, abscess. Always listen to parents because they know them the best. And if there's been a big change in behavior, that's another vital sign for you. So not a ton of research has been done on kids. Lots of what we call off-label use in the States, which means there's not been a trial done on it on that indication, but maybe for something else. And we just want to make sure that the side effect profiles are okay. I mentioned this in another class I taught, that the benzodiazepine group can be really rough on kids with autism. They get, they're always going to have anxiety, and they get really addicted to it and get higher and higher and higher doses. And then if they miss a dose, they'll sweat and be very agitated, and you won't know why a child's sweating and agitated. But if they're on a lot of benzos, you can bet that it's because they're addicted, and it's going to take them 6 months to taper off benzos. So better never to put them on that if possible has been my experience. Well, what can they go on? We have 2 drugs indicated in the States, risperidone and aripiprazole, also known as Abilify. They have FDA approval in the States for autism for mostly aggression. Those drugs can be given PRN, which is, you know, as needed. So you don't have to always ask for Ativan and Valium and all those things. Seroquel can be given. Some kids will go on an anti-epileptic medication for its sedation effect and mood effect. I've listed some there. A lot of kids have seizures and they're on valproate anyway. Some kids will, who have been developing perfectly on track, lose all their language. It's good to get them tested in case they have Landau-Kleffner syndrome, which is a type of seizure disorder. That's the paradoxical effect, that sweating and agitation that is listed there with the benzodiazepines. So some kids will go on SSRIs, which is like Prozac, and that can cause kids to act out as well, so they could have a paradoxical reaction to that. So they might not be able to go on that. It's really hard to treat the anxiety of autism with medication. That's why we try to treat it with environment and schedules. Hyperactivity, kids who go on stimulants when they're young, it seems to work well with them, but then they have horrible meltdowns as it finishes at the end of the day. So a lot of parents don't want to have them on those. And then you'll see clonidine there is good for its side effect, which is sedation. But many kids are on melatonin for sedation. We don't really recommend Benadryl or diphenhydramine for sedation. Trazodone has a lot of bad side effects, but so that's sort of a last resort. But the GI problems is a big issue, the GERD, the reflux, and so keeping track of that, and sometimes they end up getting scoped to look for issues. Right now, our little guy John's now 6, so he's got somewhere in the middle. His autism's sort of moderate. He's got some behaviors. And now he has a fever today, and he's not eating very much. Mother's thinking, you know, I really don't want to take him in because this isn't going to go well. He's going to have a tantrum. He doesn't like to wait. He appears scared. He doesn't want to get up on the table. Doesn't have a lot of language. And he really doesn't like it when people just approach him quickly and touch him. So I did a study looking at healthcare providers' understanding of kids with autism in the healthcare setting, and then parents. 2 different focus groups and developed themes. And what I came up with was that providers in this sample thought that the kids were aggressive, and parents thought they were frustrated. So 2 different, and so bringing those 2 things together means there's things we can do in the environment and expectations we can set, and things parents can tell us so that we're not doing things that are frustrating the kids. We had a lot of parents who didn't disclose, so we do encourage disclosure that your child has issues, and that, you know, let the healthcare providers know so that we can work together, and we can work then with plans and some of the things we've developed. So we know that waiting can be a problem, and that sensory smells, you know, if someone's vacuuming or other issues within the, you know, the noise the paper makes on the bed, all those kinds of things. And trouble communicating what's going on with the child can be issues. Even the staff might not know kind of what's going on. So this was ripe for you know, programs here. Providers did notice that children were uncooperative and rated that the behaviors and their just sort of not getting through fast enough was sort of their biggest challenge, and that parents seemed overwhelmed and they got distracted, etc. So a few of us across different cities, St. Louis, Milwaukee, and then there's a big autism center in Cincinnati. We got together as part of this nurse practitioner organization, and we pulled together a presentation for and a publication for the Journal of Pediatric Healthcare on what to do. And so some of these slides are from that publication and that presentation. So if you don't have anything developed in your organization, there are things you can buy that are pre-made, and they are, basic Bernstein Bears Go to the Hospital book, or Barney, or whatever, and then just some squidgy, distraction items. We create a coping kit at the hospital, but these are things. And then you can check with the parents whether the child has trouble waiting and give them the first appointment of the day, or the last appointment of the day. You can have parents take pictures of things ahead of time and create their own picture schedule, or send them a picture of the doctor so they know what the doctor looks like. And this is if you have time in preparation. If it's just an emergency room or someone you don't know, then those aren't possible things. Our schools use something called Social Stories by Carol Gray, and that was creating and foreshadowing what the experience was going to be like and how the child can behave during that, so that they know what to expect. And we have parents creating their own social stories for healthcare, and that's what led me to develop my own set of them and then creating them into an app. Some people use a communication board, which I'll show you, but in general it's good to use, have them work for something, rewards, just like typically developing kids work for tokens or rewards. These are things you can draw even on a paper towel or on a piece of paper, first this, then that. So it could be first swallow medicine, then playroom, or first whatever you want them to do. First sit, then cookie. Two-step instruction. When you think of how kids learn when they're young, being able to follow a two-step instruction versus a 3 versus a 4, that's the simplest level, is following other than following a one-step instruction, but then getting the rewards. And they might do this in order to get that. And then at a simple level, a distraction can get kids through something. Those were the books. This is a book just about waiting called Next Please. So kids can learn how to wait. So I sort of got interested in the idea of social stories and then putting them in a book format. I worked in the education department at Children's Hospital. We created those for lots of different procedures. And then we created them as a downloadable PDF because people didn't always get the books or get them in advance. And then it occurred to me that if I put them on an app and got them at the App Store, I could keep updating it and adding more to it. And kids with autism like technology. This little guy here is looking at his iPad. And by the way, that's John as he's getting older now. We're watching him grow up here. These are some of the books. This is Here We Go for an EEG. Here we go to imaging, the dentist, and the hospital. And that's at a site called MaxiShare. Anyone can download those, and they're free. But developed with Autism Society of Southeastern Wisconsin grant money, and then time donated from where I worked. So this is an example of a social story. Everyone needs to go to the doctor. It might be because we are sick, and they like using mites and sometimes. When we get there, we'll have to sit and wait in the waiting room for a few minutes. We will need to sit quietly and use our inside voice. The nurse will call our name, and we walk back to the exam room. I will stand on the scale and get measured and weighed. This is so everyone can see how I have grown. We will then go to another room. This room is where the doctor will see me. I can sit on the special table. I may have my blood pressure checked, which will feel like a hug on my arm. I may have my temperature taken. I will wait for the doctor. Okay. Other people have these kinds of cards that they carry around with them, and they put them in an order, doctor, and it's sometimes. So the key words here are sometimes and mights. Say hi, that's a social skill, so we're modeling it here for them. Wait, nurse will call your name. You might sit in a special chair. Here are the things you might see. Hi, doctor, say ah. The doctor may check parts of your body. You might need medicine. All done. The key here is say goodbye, time to go home. Some kids, our security department at Children's would say the kids don't know that they're ever going home. And he coined the phrase, label the obvious. You know, your mouth hurts. You're at the hospital. You know, oh, you'll be going home. You'll ride the wheelchair out when we're all done. Sort of like at the airport. Your flight's leaving at 12:30, not 8 o'clock. Kids need that too. Sometimes they'll have a communication board that they come in with, and they can touch things. And that's the body. They can put an X on what hurts. You can ask them, you can touch and use a visual with them. But here are the keys. They're going to slow down and maybe just talk about one thing at a time. There's a tell show before you do it. So tell them we're going to look in your mouth. Here's what I'm going to look with. So you want to touch it. It's the tongue depressor, and then you do it. So you can use some form of communication boards, positive reinforcement, praise. And a big key is adapting and working with the parent, which is what they're doing at Temple Street. You know, they have a questionnaire now they've developed, and they're working to see the parent knows the child best, and it's going to be the constant in their life. So they're going to make sure that they know what things mean, warn them about transitions, relaxation techniques, find out if they do deep breathing. You know, that could be what calms them down, or guided imagery, or whatever works for them. But one thing we know in healthcare is if they're having some kind of obsessive behavior, sort of what we call a rumbling behavior, movement, whatever, pacing, we don't want to stop it while they're in healthcare because that could put them to rage. There's a simple phrase called rumbling rage recovery, and we want to keep them out of rage. There's other forms of that with different approaches to it. But sometimes parents will be asking you about discipline, though. So discipline at home is completely different than caring for hospitalized sick children who could have a challenging behavior in a public hospital. So those are the programs you work on with, and we try to use positive, not aversives at home programs. So these are some of the things for home, because I mentioned I'd talk about home and healthcare. You want to catch them being good. Really bad behavior, it's sort of like the tantrum. You want to make sure they're safe, but you don't want to keep feeding into it. You can avoid a lot of things by having a schedule. A whiteboard on the fridge. Sometimes it's pictures with Velcro on the fridge of the order of the day, what you're going to be doing. It doesn't have to be to the minute. It can even just be in an order. I mean, a lot of times kids with autism, they expect breakfast and snack and lunch and snack and dinner. And they want their meds. They'll even come to you and say, time for meds. You know, they want Jeopardy when they want it, or whatever it is that they want, Thomas the Tank, or whatever it is. And you want to keep them engaged. They like rules. We don't believe in corporal punishment for them. So I like this little video clip, and I'm really hoping it works.
What are challenging behaviors?
I think the most important thing to remember is that challenging behaviors mean very different things to different people, and the quality of life of the individual with autism is the most important thing to consider. And when there are behaviors that are getting in the way of them getting access to the community, to things in life that would be meaningful to them, that get in the way of family life, and things that just in general people are not going to tolerate happening in certain settings are the most important things to address when you're talking about challenging behaviors.
What's the most important thing to know about challenging behaviors?
The most important thing to know about behavior in general is that we first need to start out figuring out what the function of that behavior is, because if we don't know what the function of that behavior is, we're not able to replace it for the individual that's exhibiting that behavior in a more appropriate way. We try not to focus on just getting rid of behaviors, because if we do that, typically an individual will replace that behavior with something else that's maladaptive, as opposed to something that can be used as a coping strategy so that that behavior doesn't need to happen anymore.
What's important to know about aggressive or self-injurious behaviors?
Aggressive and self-injurious behaviors are not necessarily innate characteristics of an individual with autism. Instead, it's born from frustration for the most part, and those are behaviors you and I could exhibit as well if we came into contact with such frustration. So a really simple example of that would be an individual that we were working with who was around 8 years old was exhibiting some aggressive behavior. He was biting his teachers, he was becoming more aggressive, and it was something that was not characteristic of that individual. So we wanted to rule out anything that might have been medical, any discomfort, and unfortunately it took us a little bit longer than I would like to admit to figure it out, but we realized that his shoes were too tight. And once we were able to fix that, that aggressive and self-injurious behavior diminished. Now, if we had let that go on for a long period of time, there is the possibility that once we even changed his shoes, now those behaviors would have just been part of his repertoire and a little bit more difficult to address, although we still would have been able to intervene.
So this gets to that ABC, antecedent, behavior, and consequence. So what's simple about such a complicated disorder is there's a lot of things you can put into 3 steps. So in this case, what happened just before the behavior occurred? What was the behavior? Was it biting? Was it screaming? Was it whatever it was? And in hospital settings, sometimes it's just noise before it, a demand usually, that's something they don't want to do, or, and then what happened right after it. If they got something good by doing the behavior, if every time they did something you gave them a cookie, they might do it just to get the cookie. So that's why you have to map all 3. So the antecedent is the A, the thing that happened just before the behavior, and then the consequence. That's important. I see some of you writing, so I always want to be sensitive to that. Anybody got an example? Is that something jump right to mind now? Of either someone you know with autism? In healthcare? I got a lot, so I'm just waiting to see if you guys have any. So we have, again, I taught a lot of classes at Children's Hospital because we have staff orientation on this topic. And I co-teach with someone from the security department because security was the one getting called with all the challenging behaviors. So they came to our department and said, we need education. And one of the security guy who came to us said, I have a son with autism, I can help you with all this training. And then I said, coincidentally, I have a son with autism. And then it turned out there was an emergency room nurse who had a son with autism. And then it turned out there was a physical therapist and a speech therapist. So we pulled together a whole committee, and then we created our education, and then we started, all of us took turns teaching it to the new staff. We did some online, and then we did some in-class stuff. So that's how it all happened. But one of the stories he used to tell in orientation was he would get called to, well, the first day he got called to the 7th floor, and there was a girl having a meltdown at 7 o'clock at night. And his thing was, he was a big man. Whenever anyone had like a meltdown, he always thought they were hungry. So then he said, get her something to eat. So she got some pizza, heated up, right? And she stopped the meltdown and she had the pizza. Well, then the next night, 7 o'clock, he got called up there again. He was working, and she was doing the same thing. So he goes, get her some pizza. So, and then she stopped. Now, you wouldn't want to do that if that was your daughter at home, right? But in the hospital, we're just trying to keep order. And so in that case, rather than putting her in restraints or, if it's healthcare. So I'm just saying in that case, she was hungry. So I don't know if that's the best example. That's why I was waiting to see if you guys had a better one. But that's an example, right? And that's survival in a hospital. The other thing we found too was that we had this child life department, and these are 4-year college degree, and they helped us with our procedure preparation. And in Cincinnati, where I did this work with another nurse practitioner, they had, 50 child life specialists, and we had maybe 5. So, and they had this whole autism program, and before kids went in for surgery, they had a consultation with child life, and they had all these squidgy toys and everything. That's what I found out about. It turns out they had a donor give them all the money for those employee positions because they thought it was important. So then we started thinking, well, we could do it here. We could get the nurses to do it. So we created a kit, and we did a survey of what we thought should be in it, looked at the evidence. It had to be things kids couldn't choke on and that were visually interesting. So think of an infant, how they like to explore by mouthing. So think of an older child. Sometimes if you work with developmental disabilities or autism, they still mouth stuff. They still like things that are cause effect, like a rat, you shake it, it makes a noise, and that's it. You don't have to read the rules or, you know, spin a wheel or have cards in your hands. It's just, or pretend something, it's just cause and effect. So then we found the items and we found that they were safe enough. They have all these special needs catalog. A pad and paper to make a list so you can cross things off as you go. The social story that I developed, the first one, which was Here We Go to the Hospital, that ends up with somebody being wheeled out the door so they know they're going home, and I did a great job. The buzzer, the face. Kids like things with faces, and I think that's why apparently they like Thomas the Tank Engine and emojis, because they have a face on them. We developed health facts teaching sheets about the coping kit, and then I did a research study that we got published showing that nurses were willing to go get it off the shelf and use it because they found it useful. Because that was a big thing. You can make all kinds of interventions, but if no one uses them, it's like a waste. And we got funding again from the Autism Society, so we partnered with them. Then I moved on to developing individual apps, because I got some funding and I did individual apps for all kinds of imaging. Here we go to X-ray, here we go to MRI, and I did a 2-year study with a randomized controlled trial, 2 research assistants, 1 blinded to whether they got the intervention or not, and I did it with the parents. So I showed the parents this little social story of what it was going to be like when their child went back, and I did a pre-post state trait anxiety on the parents, showing the parent what it was going to be like, decrease their anxiety. It even statistically significantly decreased the child's heart rate after they knew what was going to be happening when I went back there. And the kids who got the social story also got through the procedure faster with fewer challenging behaviors, according to a behavior observation tool. And that was published. So that was kind of finally some evidence that social stories work. We do a lot of stuff in nursing, but if we don't do research, everyone just says, oh, there's no evidence to that. So once we did that then, we were able to buy iPads then for the child life people, and more they started then hiring more and more child life people too, which is also great. Because they're recognizing that their work makes a difference with throughput and fewer challenging behaviors and possibly staff injuries. So now we're starting to document the value of our procedure preparation work. And by decreasing the family's anxiety, you're also helping the child get through a procedure because it's a full package, right? This is what I've referred to already, 4 to 18-year-olds, English speaking, the 2 researchers, so that the one that was, they're blinded to whether they got the intervention or not. And those are the scales I used. I collected all my information. These are the individual iPads. I collected my data on the iPad. So what we then found was that we started to do this anxiety-reducing parent consultation. We wanted to know in advance how they prepared their child for their procedure, past exposures, how they wanted to be involved, and then my big one was what reward are they working for today? So that's what we've started doing is looking at that. And we're hoping on a theory level that the iPad intervention strengthens protective factors and positively impacts the whole family outcome, both the individual of the child and then the families. This has all led to more social stories that I've developed over time, and this is the handout that I gave you. So for those of you who, does anyone here have an iPhone? Okay, it's not yet for Android, but right now if you go to the Apple Store and you enter Autism Healthcare, here we go, you can download it, it's free. Doesn't mean it was free to make, it was very expensive to make through grants, and but it's out there now, it's copyrighted, and there's 2 for blood, 1 is for blood draw, and the other is for infusion clinic, and then EEG, imaging, the 4 kinds of imaging, dental surgery, and then the emergency room one's not the greatest one so far, it's just that hospital one. So, and then there's a room under home in order to take notes on different things. And then the research one is an interesting one. I developed that for teenagers with autism who want to participate in research studies. There's a lot of forms to fill out, and then it's scary to be in an MRI for an hour and a half. And lots of the teens wanted to be in it. There's studies that they're doing at Marquette in biomedical engineering, but they weren't able to lie still because they didn't know about lying still and the noises. So it's one thing to put them in a mock scanner, but that itself really wasn't enough. So then they were disappointed because they didn't get their stipend that they'd been promised, and we had one girl, I did a focus group with them after the fact about the use of the app, and she said, well, I didn't get the app, so I wasn't able to lie still, so they never called me back, and I really wanted that money because I knit and I wanted to buy wool. She was quite upset about it, yeah. So when you think of it, we think, you put people through research studies and it's voluntary. Some kids really want to be in them. They want, and adults want to be in them. They want the gift card. And they want to help. Those were the other themes in the study, was they really did want to contribute. Some of them said, I have mild autism, but I know other people have it worse, and I can do this, and if it helps somebody else, I want to do it. So there are some noble reasons to be in research. So I do encourage you to download that, and we're going to be pushing out updates that there's some typos in there. And then hopefully along the way, as I do get more grant money, I want to develop an Android version and then create more social stories in there. So the staff training I alluded to earlier has an online component, and then it has some videos with a chance to practice. This is Joel, the security fellow I was telling you about, and a much younger me about 10 years ago when we started all this work. We called ourselves a Behavior Challenges Committee, and we realized that every child has the potential to go into crisis in fast-paced hospital environments where there's an expectation for cooperation. However, children with impaired communication skills are at the highest risk for exhibiting challenging behaviors, said Johnson. So that's me. They wrote about us, and we've been still doing this training, and we evaluated it and published that, showing that staff after the training were less fearful about working with kids with challenging behaviors because they knew what to do. They had a chance to practice some of the skills we taught them, and that they had improved confidence for working with families. The social stories are part of that. We also created just-in-time teaching sheets, which are on our intranet within our hospital, that talk and has all the steps about preventing and management of a behavior outburst. We have health facts for family members, simple 5th grade level language, what autism is, what are their resources. And we developed order sets in our electronic health record. All children with history of challenging behaviors, autism, or a brain injury will get a social work consult and a child life specialist assigned to them, and for distraction toy allotment, and then social work looking at how the parents are doing, what their needs are. And then there's also an order set in there too for medications, etc. consideration. So if I were to sort of summarize about what communication's important is the partnering with the parent. Again, at Temple Street the other day we did a talk, and one of the nurses there was just wonderful. They're doing this a really good job with partnering with parents and using that as the first step. Based on everything I said today, I would say it's a lot about setting expectations and giving warning. I was lucky enough to spend a day at a school, thanks to Suja, who's a professor here. They had a laminated piece of paper. It had some Velcro on it. And it had a 5, a 4, a 3, a 2, and a 1. We were on the playground, and they showed it to the child. 5 more minutes, and he's swinging and having a great time. Then they ripped the 5 off. Then they showed it to the child. 4 more minutes. Then they ripped the 4 off. And then when it was done, the child got off the swing. Can you imagine? Time to get off the swing? No, I don't want to get off the swing, right? Or okay, the alarm clock, when the buzzer hits, you're done, and then the buzzer hits. You know how the sound of that is horrible. So those are kinds of things you can do. Even if it's on a piece of paper, cross out the 5, the 4, the 3, the 2, the 1. Again, simpler, fewer commands. Some of the things here I've mentioned already. So now today is the day we get to see if the videos work.
Sam?
Yep, that's us.
You guys want to come on back?
Sure. Hi.
Where's it going? You could buy you a McDonald's in Marquette University.
Hi, Mrs. Johnson. I was just reading through Sam's chart here, and I noticed that he's autistic. Are there things that work for you, like directions to help Sam get through things like this?
Yeah, what usually works is just 1 or 2 words, keeping it just a few words.
Okay, okay. All right. Sam? Hold on 1 second, okay? Okay, Sam, stand. There you go. Good job. Let's see how big you are. Perfect. Great, Sam. Can you come stand? A little loud noise here, okay? All right, stand straight. Look tall. Okay? Great job. And that's how tall you are, Sam. Good job. Okay. Sam, can you sit? And Sam, this is going to give you a little hug, okay?
You ever danced at Marquette University?
Okay, Sam. Little hug, okay? You're doing a great job, Sam.
You ever danced at Marquette University?
Marquette University?
McDonald's?
At McDonald's?
And yes, US Bank? Gee. No, God.
You're doing a great job holding still.
Kindergarten.
You're doing a great job.
In kindergarten. Kindergarten in first grade.
Yeah?
First grade.
Almost done. Look at that, Sam. You did a great job. You did a great job holding still. Can you give me 5? Awesome.
Huh?
And now we're going to go back to the room, okay?
Okay, thanks.
So I could give you some background. You probably wonder, why is he talking about McDonald's and the U.S. Bank and Marquette University and kindergarten and first grade? Do you think that there's any rhyme or reason to that? There is. But you don't know that because you have no idea. You don't know anything about him. So what would you do if that was something serious that we needed to know what he was talking about? Who would you ask? You'd ask the mom if it mattered, right? Otherwise, you just ignore it. So if you haven't guessed yet, that's me 10 years ago, and that's my son Sam. And we were working for a visit to Dad's office at Marquette University, which is next to the U.S. Bank, and McDonald's. And when he goes to Dad's office, he gets to play Jumpstart Kindergarten and Jumpstart First Grade on the computer. So he's thinking, if I'm good, I get to do all those things. McDonald's on the way, Marquette University, which is next to we only had one tall building at the time. It was this really cool U.S. Bank building. You get it? So it all made sense in his world. It just doesn't make sense to us. We have a few more. These are the things we do in orientation. Oops, I don't want to do that. Look, I got it to run myself. All right, so our strategies are one voice, and we have a video about one voice. We have a directive cycle. That's why he pointed to the chair, because we teach them how to get kids to sit down. And then we have an 8-step communication that starts with name, occupation, doing, or smile, name, occupation, doing. I think you have that movement here too. We have to remind people, you have to tell them who you are. I'm Norah, I'm the nurse. I'm going to come in and look after you today. And then you label the obvious. Your belly hurts. So then they don't have to be all doing all this to let you know their belly hurts. You're telling them your belly hurts. Even we do that when we do affirmation. When you watched that video earlier and the woman was talking with the parents, and she'd say, oh, that had to be hard, or whatever. We do that all the time as nurses. It's one of our skills. So affirming, your belly hurts. I'm going to help it feel better. You can hold the ball, which is your distraction. Your mom can stay, so now you're helping them. You know, these are good things. You're going to get an x-ray. Good job holding still. So this is our video for one voice. Now this is an actor.
Tate, don't start this now, okay? Tate, settle down. They're just going to come in and take a look at you, all right? You don't want to be sick anymore, do you?
My name's Annette.
Then you got to let them look at you, okay?
I brought all these great things for you.
Come on, quit that.
Look at what I brought.
No, watch that
Look
with
at
your
what I
hands,
brought.
Tate. Keep your hands
Fans.
down.
Hi, Tate.
Tate, you are just overreacting. Now, son, settle down.
Can you look at me? Calm down, Tate. You look
Tate,
at all these
calm
things.
down.
Look at what I brought.
They want to help you, Tate. They
Look
just
at all
want to
these
help
things.
you.
When you're done, we'll get you some. Yeah,
Tate,
love
look at
your
her.
stuff. Hi, Tate. My name's Annette. I brought some things for you. Dad, you can stay in here. We just wanted to give him some space and some quiet time.
There you go, Tate.
That's the app with the site, but I gave it to you on a piece of paper so you can find that. Play around with it if you have it. If there's, you can talk to me afterwards if you want to know more about it. Those are the earlier apps, the books I mentioned, the coping kit. Got a couple more videos. Let's show them.
Alex, can you come up on the bed?
Good job.
Good job,
listening.
Alex. Good listening. Okay, we'll have the child life specialist come in, and then we'll be back in with the doctor in just a few minutes, okay?
Okay, thank you. Alex, do you want to go over this? Can you put this down? Okay, quiet hands. So, Mom will be with you, okay? And we need to see the nurse and the doctor, okay? Alex will have a quiet mouth, quiet hands, quiet feet, okay? Do you want to play with your toy until she comes? Okay. You use your voice if you need to, okay? All right.
Hi, I'm Dr. Chatla. How you doing?
Hi, Dr.
Alex.
Chatla.
We're just gonna cut this open here, take the bandage off, and take a look at your wrist. Okay?
Can you see your hand?
Is it okay? It's not gonna hurt at all. Okay?
You can still hold on to your toy. You squeeze your toy, and I'll hold your hand, okay? They're going to look at your owie. Right? It won't hurt.
You're doing a good job, Alex.
You're just gonna feel the plastic over here of this going on your arm.
Good job. Quiet hands.
You're doing great. Okay, here we go. Okay, well it looks like we're probably going to have to put an IV in and get a couple of stitches, okay?
Quiet hands. Okay.
Okay?
And will he get some medicine before?
Yep, we'll give him medicine so he's calm and doesn't feel any pain too, okay?
Okay.
Alrighty, we can go ahead and cover this back up. And we'll go get the rest of the stuff that we need, okay?
Okay. All right.
Thanks.
Thank you. Okay, let's just keep that covered now, okay? Leave it alone. All right, you play with the ball. Good job.
We have lots of resources in the States. These are the main ones that I have listed here. They have websites, they have toolkits and videos and all kinds of things here. And let's see. I think I'll leave those up. And then I think all I had left was references, so I can open it to questions now.